Welcome to Capnography for EMS.com, your source for EMS education pertaining to capnography and anything related. Capnography by EMS for EMS. I'm your host, John Syverth. Today we're going to be covering waveform recognition. We're going to be covering a decent amount of waveforms, but before we get to that today, we'll be doing a bit of a review of the first session we had regarding the basics of capnography. First off, the most important slide with the most important words. Capnography, the vital sign of ventilation. With capnography, we're tracking the carbon dioxide in the patient's exhaled breath. We're objectively evaluating the patient's ventilatory status, and we're indirectly evaluating the circulatory and metabolic status. All three, I repeat, all three must be present for carbon dioxide production. When we utilize capnography, we take that in mind, all three of those parts of capnography. It assists us, the caregiver, with clinical judgment to assess and treat our patients. Now, with ventilation, perfusion, and metabolism in mind, the one thing that we need to remember is end tidal CO2 is the end exhalation measurement of carbon dioxide. So when we have end exhalation, we can think of that as the carbon dioxide coming from the deepest part of the lungs possible that can be expelled through all of the dead space areas such as the trachea and the upper part of the lungs really. And what we get then is that measurement of end tidal CO2. We need to remember that for end tidal CO2 to be a normal measurement, we're thinking 35 to 45 millimeters of mercury. Anything outside of those parameters, we need to delve into figuring out what exactly is going on with that patient. Is it a poor tracing? Is it artifact? Or is there really something going on with one of those three things we just mentioned, ventilation, perfusion, or metabolism? We'll get into great depths later on about that regarding each one of those three. But nevertheless, it could be any one of those three or any of the combination of those three. So you could have ventilation or perfusion issue, or you could have ventilation, perfusion, metabolism issue that is skewing what your numbers may be. Now, since we're going to be discussing waveforms today and waveform recognition, this slide is also good to remember what our waveform should look like. And though this is my drawing, this is relatively similar to what a waveform should look like. And if we remember our analysis, this is our exhalation with our first initial washout of dead space air with carbon dioxide coming from the lower part of the lungs and the middle part of the lungs and such. And then we have our alveolar plateau, which is where that carbon dioxide, like I just said, is coming from the deepest part of the lungs. And so therefore things start to level out a little bit because the mixing of the gases isn't really happening anymore, and you're getting more carbon dioxide rich air that's been directly translated from the bloodstream. Now, looking at this waveform, we can see that we're relatively square in shape. Okay, and remember we talked about the alpha angle. That alpha angle is about as close to 90 degrees as we can get, and normally it's 110 degrees. I only say that for illustrative purposes. People freak out all the time. We're paramedics and we don't like math or angles or numbers for that matter. But that's really about the extent we'll get into that. It's important to remember what a normal waveform looks like, and if we don't have that, we need to investigate as to why. Moving right along, let's remember that D down to E is our inspiratory phase, and from E pretty much to B really is what we're talking about. That's kind of like that post-inspiratory phase where we're maybe holding our breath in, and then B to E is that first bit of exhalation, and then that alveolar plateau, which we just mentioned in the previous slide. Okay, we need to think about that, and every once in a while we need to think about how we breathe. Okay, from D to E, we breathe in, and B, C to D, we're breathing out. So let's get down to what we set out to do today, and that's to look at waveform recognition. And we're actually going to look at real waveforms because not all waveforms are the same, and we need to get the basic understanding. Just like a 12 lead, not all 12 leads look exactly the same. We may have some variations, but if we understand those foundational concepts, then we're going to be a lot better off in being consistent with our interpretations. Now, if you're looking at this slide and you're saying, well, that looks like a normal waveform, you are correct. And you can see here that respiratory rate is 8. And this was me breathing at a normal respiratory rate for me, which most people are actually around 8 to 12 times per minute. And when we're ventilating patients, we're, say, using a bag valve mask under normal circumstances, especially during most of our typical CPR or cardiac arrest, we should really be ventilating our patients around 8 times per minute. Now with this waveform, you can see that it is relatively level. You can see a little bit of sloping, and maybe that's me looking at the monitor a little bit. But for the most part, we want that relatively square looking waveform. Unless the patient is symptomatic, I'm not going to get too excited about this little bit of slope here. But if it was, that little bit of slope would indicate to me that there's some type of exhalation delay. Now, being that it's so slight and small and it's towards the top of this waveform, that tells me that it's a later part of exhalation, because if we think about it, this is the part where we start transitioning over from that dead space over to that rich alveolar carbon dioxide and exhalation. So this is coming from the deepest part of the lungs right here. Okay. So what we have here, like I just said, a respiratory rate of 8 per minute, but also a normal waveform. And if we look at this reading here, I'm a little bit off, but this center line is going to be 35 millimeters of mercury. Okay, so when we're looking at most of our strips today, these are pulled from a computer, so a little bit more clean and crisp. The orange ones are our standard strips that have been scanned in or what have you. But when we're looking at these strips, we're talking about roughly a 10-second strip, and we'll just say for this purpose it's 10 seconds. I think most of these are like 11 seconds or something. But each one of these squares, these big squares, is about 1 second. Okay, so if we take a quick count, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, so if we're measuring this respiratory rate, 10 blocks over 60 seconds is 6, and I see 2 blocks, not even 2 blocks. So at worst, we're talking 12 breaths per minute, but according to this readout here, it's 8 breaths per minute. We have to remember that the respiratory rate that's being measured by your machine is a rolling calculation. So if someone stops breathing, but their respiratory rate was 35 to begin with, then the rolling rate is going to slowly decrease. It's important for us to recognize that, because we may actually have a waveform and then no ventilatory status at all. Our measurement here may have been 35 millimeters of mercury, and it goes down to 0 millimeters of mercury. However, our respiratory rate here was, I think I said 35, right? Over here, our respiratory rate we would normally think is 0. However, there's a rolling average, okay? And so the rolling average over the course of time is going to actually decrease down to, say, about right here. It might be 32, and then further on down it might be 28, and yada, yada, yada. So if we're looking at just the numbers and not the waveform, we're going to not serve our purposes of monitoring ventilatory status, okay? So this becomes particularly important when we're confirming tube placement, and when we're whether that's a patient that we're performing CPR on, or if they have their own pulse still and we're doing some type of rapid sequence intubation. We're always doing tube conformation and ventilatory status conformation based on waveform. Okay, we're not looking at just numbers. Numbers do come into the picture, but waveform has to confirm ventilatory status first. So here's some more waveforms, and I'll let you take a quick look at that for a second. We can see 3 different strips, and this one's a little bit more difficult to see. Let's see if I can get this to work for you. This top waveform, we can see we have relatively normal. And like I said, these are people breathing. People do different things at different times, right? They may be hiccup or gasp or have an irregular respiratory pattern every once in a while, which may be noticeable on this waveform. They're not necessarily clean and crisp, but unless they're symptomatic with some type of ailment, I'm not going to get too worked up over it because it just may be an aberrant respiratory pattern. And it may be just something that causes a difference in the fluctuation of carbon dioxide very briefly. What's important is that we're looking over that waveform over the course of time. If we see one abnormal waveform over the course of 20 or 30, I'm not really too concerned about that. If I have significant waveform changes consistently throughout the assessment of the patient, whether that be over the minute or 30 seconds or what have you, then I'm definitely going to be more proactive and figure out what's going on with that patient. So if we're going to think of a waveform analysis the same as an EKG, 12-lead EKG, we look at different things for 12-lead EKG, right? We look at regularity, we look at rhythm, we look at rate. Okay, those are all for the same purposes, maybe not exactly the same, but we're looking at regularity of respiratory pattern when we're looking at a waveform. We're looking at the rate, and we're also looking at the size of the waveform. Now, size of the waveform, especially initially on when we're looking at ventilatory status, can give us a better indication as to what the numbers actually are. For example, in this illustration, it looks like to me that 37 millimeters of mercury may not be entirely accurate for these waveforms here. Okay. These look a little bit low, and it's kind of tough on this old tracing to know for sure. But I would gander to say that this end tidal actually at this point may be more like 25 millimeters of mercury. Okay. So it's important for us to look at the waveform first. We're looking at regularity to see if the rate of the respiratory rate is regular. If it's regular, what the rate is it in adequate in the adequate parameters, so 8 to 12 per minute. Okay, and what about the size of the waveform, the shape of the waveform? We can see here that this one, the waveform is actually relatively normal. Now let's move up here for a second, and these waveforms look a lot better. Okay, the middle one here that we just moved to, this one obviously looks much more regular. The waveform is much more crisp, a little bit better looking overall, but we can see the respiratory rate is actually increased a bit more. So this patient might be actually hyperventilating slightly, maybe a respiratory rate of 20. Okay, and the end tidal may also be on this patient 25, somewhere in that area. Going to the next one, we can see the respiratory rate is a bit quicker, and if we're comparing the waveform from this one here to this one, we can see the waveform is not quite as long, which may indicate that we have a quicker respiratory pattern, or it may also indicate, which we'll discuss a little bit later. Let's get a little ahead of ourselves, but it may indicate that the tidal volume is kind of crappy. However, this waveform is relatively crisp and clean. There are some variations a little bit where there's some rounding, but that looks like it might just be an aberration based on this patient. So in this instance, we may actually have a higher end tidal CO2, maybe closer to 30 to 35 based on the other ones. However, the respiratory rate is a little bit faster as well. Okay, so rate, regularity, size, and rhythm, so to speak. So how about this waveform? This waveform, if we're looking at it, we see that we have regularity between each one of the waveforms. So the respiratory rate is regular. However, we have quite a bit of respirations here. If we're counting our 10 boxes again, we have 1, 2, 3, 4, 5, 6, roughly 7. All right, 7 times 6. Not much of a math whiz, but I'd say that's about 42. Okay, at the best, we're talking 36 respiratory rate, 6 times 6, if we don't count this last waveform here, since we're between 10 and 11 blocks. We can also see that our waveform is decreased. Okay, the size of the waveform has decreased. Even though it's nice and square and normal looking, our baseline, or our level of 35 millimeters of mercury, is over here by this red line. So we're much lower than that. So this is a case where the respiratory rate is high and the end tidal is low, and we also have a normal waveform, and we have a decrease in size of the waveform, okay, which is reflective of that low end tidal. Okay, this in reality is our typical hyperventilation. We have high respirations and low end tidal CO2, and we have the low waveform, which coincides with that low end tidal reading. In this case, we may have a very regular respiratory rate where we can rely on the numbers on our monitor to be consistent, that rolling average to be consistent with the size of the waveform, which in a glance may be a more immediate recognition of whether or not our end tidal is actually high or low. So here's a bit of a different scenario. And if we just kind of figure this was a 10-second strip again, which it very well may not be, but actually it's probably less than that. This is really more of a hypoventilation. Okay, so this rate may actually be under 6 per minute. Now the interesting thing about this is, even though the respiratory rate is low, the end tidal, or the waveform, is very tall. Okay, you can see over here on the left, end tidal of 50 in this illustration is right here. So we're well above the normal range of 35 to 45 millimeters of mercury. And we have a decreased respiratory rate, an increase in size and waveform, even though it's normal. Okay, so we know the patient's exhaling properly, and being that we actually have a lot of carbon dioxide being expelled, we can deduct that most likely with the normal waveform, nice and normal and square, and the exhalation of carbon dioxide that's this high in levels, we can deduct that this patient is hypoventilating by respiratory rate only, and they actually have good tidal volume. Now, we have to take that with a grain of salt, because there's two types of capnography. The capnography that we work with in the field is called time-based capnography. So we're measuring things over the course of time. If we had patients upstairs and we had all this fancy equipment, we might be able to do something that's volume-based, where we're taking blood gases and we're measuring the volume of carbon dioxide, and we're comparing the two to determine whether or not that patient is actually dead space ventilating too much or not enough, whether or not they're exhaling enough carbon dioxide to comparing to what's in the bloodstream. Okay, for our purposes, we don't need to worry too much about that, but we can evaluate the waveform, and if the waveform is abnormal in some way, it may mean that that patient doesn't have an adequate tidal volume. Okay, and this next slide that we have will be a good illustration of that. Here's a patient that we had where he got called to a nursing home, and she was called in as an unconscious, and the nurse said, well, she was fine all morning this morning, and all of a sudden she was just unresponsive. And so we hooked up to a cannula while we were doing our initial assessment of vital signs, blood pressure, the standard vital signs, blood pressure, pulse ox. Even though pulse ox isn't our standard vital sign, we always do it right away, and blood pressure and all that jazz. And we have an adequate respiratory rate because we're looking at it here versus just eyeballing it. And this is the waveform that was presenting for us. Now you can recall from what we were just discussing, a normal waveform should look like this. Okay, and you can see here, if we're going to march out this reading, this patient actually probably has probably about 18 respirations per minute, and then give or take a little bit here or there, but by far not hypoventilating as far as respiratory rate. So the respiratory rate is actually normal. However, waveform, well, that's not normal, right? We definitely know it's not normal. So what's going on? What's going on is, okay, we have a good rate, rate's good, but what about tidal volume? This is a great example of a patient that is technically hypoventilating, even though their respiratory rate is good, their tidal volume sucks. And the reason their carbon dioxide levels are so low is because the carbon dioxide rich alveoli are not fully being removed or exhausted from the chest because the tidal volume sucks so bad. So all this patient really is exhaling is a little bit of mixing of carbon dioxide with that dead space air in the upper part of the airway and the trachea. Okay, if we think about the lungs, which we haven't discussed this too much, and we'll get into it later quite in depth. Further down in the bases of the lungs, we have a lot more blood volume circulating as compared to the upper part of the lungs. On the contrary, we can actually have a lot more air circulating in the upper part of the lungs versus the lower part, just based on physiology, but also because of the displacement of blood in the lower part of the lungs. However, ventilation and perfusion together match better in the lower aspects of the lungs, which is where the majority of our gas transfer of oxygen and carbon dioxide happens. So this patient, even though there might be good gas transfer of oxygen and carbon dioxide down in the lungs, the gas transfer, the gas exhalation of carbon dioxide is inadequate, which is showing this poor reading. So if you ever see a waveform that has this type of look to where you have, maybe it's even a little bit more pronounced, but we're getting rounding, okay, start thinking that that ventilatory status may be inadequate simply from a poor tidal volume where the patient is not getting their true end exhalation in. Okay, so rounding may be consistent with some type of delay in exhalation with bronchospasm or something, but typically when we have more of the rounding effect like this is showing here, okay, we get a little bit more of a rounding effect, then that typically will mean that there's some kind of poor tidal volume, and we can't necessarily rely on the old adage that end tidal CO2 is equal to PA CO2. Remember, PA, the lowercase a, is arterial. In this case, PA CO2 will be much higher than what our reading is on our end tidal CO2 in this, because right here we're probably measuring around 15. millimeters of mercury. Okay, that's something called a VQ mismatch. On the very basic terms, this is a VQ mismatch, even though most people just call it hypoventilation, and the actual term for this is hypopneic hypoventilation. We'll get into the VQ mismatch much later on. That's a whole nother bear to tackle there. So here's some examples of bronchospasm, and we've talked a little bit about bronchospasm, or what I also like to call is delayed exhalation, because it's not necessarily just bronchospasm, but that's the most severe type of case that we may be encountering it. We do need to know the difference between delayed exhalation versus bronchospasm, because there may be times where we do have an abnormal waveform mimicking bronchospasm, but could be something as simple as adjusting the airway so the patient's tongue doesn't fall in the back of their throat. So let's take a quick look at the lower strip to begin with. And this one's a little bit more in tune with what we expect a bronchospasm to look like, okay, or also known as a shark fin waveform, because it looks just like that, right? We have a shark fin kind of appearance, and if we remember correctly from earlier, that shark fin is a delay in exhalation, which means we have a lot of restriction in most cases for those asthmatics or COPD patients. We have a restriction or a narrowing of those bronchioles that are preventing air from escaping from the lungs and the alveoli. Okay, so that's where oftentimes we get air trapping, and we get that restriction of exhalation, and it's also where we may often find expiratory wheezes as well. So one important thing to remember is that we're not always going to see that true shark fin waveform. If we think about this illustration here, this shark fin waveform is very broad and very pronounced. And what we're missing there is that initial carbon dioxide washout that is mixing with the dead space air. So when we have a much more profound shark fin, that means that waveform is a pretty severe looking one. The other issue we need to remember is that when we're looking at a monitor screen, that's much more different than looking at a printout. Just like we do 12 leads and we push the print button to do our diagnostic analysis of a 12 lead, we need to be doing that with an EKG as well. Now, this illustration here is probably much more reflective of what we would see on a monitor screen. And once we get to the next slide, we'll show you what a printout may look like on varying degrees of shark fin or sloping or bronchospasm, however you want to say it, delayed exhalation. So let's look at the waveform above here, though. Now let's look at this waveform and reduce that a little bit so it looks a little bit better. This one we can see is most likely would be a screenshot of on the monitor as well. It's condensed in time, so it's a little bit easier to read, even though it's not truly diagnostic, like we said with the printout. And we can see here that the waveform is relatively upright to begin with, but then starts having this broad, pronounced sloping. Well, if we think about that lung again, this area right here is where we start getting into that deeper part of the lung, where we're richer in carbon dioxide, and we start beginning that alveolar washout. So even though we have that normal upright pattern here, we need to pay attention to where we maybe start sloping, which may give us a better indication as to how early in the event we are at with some type of bronchospasm related to asthma or COPD, or maybe mucus plugging related to COPD. Okay, and this may give us an idea whether or not we're early in the process, or we're getting better, or we're getting worse. If we start getting down to this waveform from this one, well, we're getting worse. If we're moving to a waveform up here, then maybe we're getting a little bit better, because we can see with this waveform, it's almost squaring up, but this is quite a bit of a rise yet for our waveform, and we can also see it's on the higher level of what would be normal. So not only do we look at the waveform shape in this process of bronchospasm, but we have to look at our height and i.e. our numbers. Okay, if we have a waveform that it's getting better and our numbers are leveling off, then we may be making progress. If our waveform is worsening and our end tidal reading and our waveform height is actually normal, that doesn't necessarily mean the patient's getting better, especially when they're presenting with an asthma attack or a COPD exacerbation. Okay, so we have to look at all of it. Okay, we have to think ventilation, perfusion, metabolism. We have to evaluate the waveform. We have to evaluate the numbers, and we evaluate the trends. So here's a set of waveforms. I believe the first two are from an asthmatic that also was having an allergic reaction and maybe freaking out a little bit too. And then the bottom one is a patient that was being bagged, and we couldn't quite figure out what the underlying etiology is because we were not there for a respiratory problem, and I believe we ended up sedating and intubating this patient. Nevertheless, if we look at the waveforms for all of these, okay, they all have a consistent theme. That being, the waveform is not necessarily upright, but following more of that shark fin pattern. Now, this is what would be consistent of what we would see on a printout versus what's on a screen. What's on the computer screen, like I said, is condensed, or on the monitor screen is condensed. So this is a little bit more representative of what we may be seeing, and we cannot be mistaken that this is a normal waveform, okay, that any of these strips are normal waveform. They're just not. Okay, if we get into that alpha angle thing, which we don't want to get too far into it, right? Normally we're about 110 degrees. We can definitely see that this alpha angle is much, much more profound and probably at least 140 degrees. Okay, so abnormal waveforms, and this would be indicative of delayed exhalation. And in the face of this patient with a history of asthma and an allergic reaction where she was allergic to nuts and ate some Chinese food, I think we definitely say that we have some type of bronchospasm, bronchoconstriction, respiratory involvement, direct respiratory involvement with an allergic reaction. Now the other side of the coin to look at here is, we mentioned before that this line right here is about 35 millimeters of mercury. Okay, her waveform height is actually pretty normal, which probably means her end tidal is relatively normal as well. However, she's breathing much faster. Look at her respiratory rate. Okay, her respiratory rate's actually pretty moving along pretty good. Okay, it's a little bit faster than what it should be, and even though we have this bronchoconstriction, we'll just call it, or delayed exhalation, her end tidal level is actually relatively normal. So for me, I know we have a respiratory rate that's increased, which should decrease CO2 all in itself. Okay. However, we also have that delayed exhalation, right? Delayed exhalation typically will hold back the amount of carbon dioxide that's being exhaled at one time. So really, we should have an increase in carbon dioxide. So now it gets even more confusing, because normally, if we had just a increased respiratory rate and decreased CO2, we would consider it hyperventilation, right? We have a delayed exhalation. Over the course of time, as a waveform gets worse and worse, we're going to have an overriding amount of carbon dioxide building up in our end tidal levels. So this patient's a little bit unique that there was also that, remember, allergic reaction. Well, what happens in allergic reactions? We pretty much have a distributive shock developing in this patient. So she's She has an increase in respiratory rate. Her waveform is sloping, but it's not terrible. So we may not have too much gas restriction or gas being restricted from exhalation as far as carbon dioxide goes. But we may also have a perfusion issue. Okay, so remember, we're thinking ventilation, perfusion, and metabolism. Now that I scribbled all over the screen, let's move on. Okay, so here's some much more profound waveforms with bronchoconstriction. Okay, this patient was an asthmatic that called us a little bit later into the game, and with our initial assessment, decreased lung volume as far as being able to hear anything, and this is what we were finding on our waveform analysis when we hooked up the capnography for the initial assessment. And these first two are the same fellow, and this is pre-CPAP for us in conjunction with aerosols, where we normally did not do CPAP for those types of patients, which we are now. However, we were right on the cusp of getting that in line with our protocols, and we went ahead and we had two choices with this patient because he pretty much ripped off his nebulizer mask and said, "I can't breathe, I can't breathe." And what ended up happening is, we can't see it in these strips too well, but his waveform was worsening, okay, just like it is now, except his end tidal was shooting up towards the 60s and 70s and maybe even higher than that. So what was happening? Well, he was fatiguing, and he was working so hard to try to get that air out of those narrowed bronchioles that he could no longer force out that air. So he had a decrease in respirations. He had a spike in carbon dioxide, which meant he was an impending respiratory arrest. Okay, he was becoming hypercarbic. And when he's becoming hypercarbic, that means he's not really getting oxygen to his body either. So now he's starting to panic, which goes with the I can't breathe feeling. If we have too much carbon dioxide being exhaled from the lungs, most likely that means that we have very, very poor alveolar ventilation, okay, which is indicative of that waveform as well. So we had two choices. We could bag the guy and wait for him to get sedated and everything else, and then we'd intubate him. And with intubation, we would maybe accomplish a little bit, but we still have the underlying issue of that bronchospasm, and we're not going to be getting any better. So what we chose to do is go ahead and do a last-ditch effort of CPAP. Okay, and we all know that CPAP is definitely a better option than having to wait to ventilate somebody and intubate somebody, especially in this circumstance. So CPAP earlier on would have been ideal with the conjunction of a nebulizer mask, or I'm sorry, nebulizer treatment, maybe a combi vent treatment. But we didn't have that choice at the time because our CPAP was only set for the higher settings, which was 10 centimeters of water. So realistically, 10 centimeters of water might be too much for our typical asthmatic, but for this patient, he actually was in such bad shape that 10 centimeters of water, he was loving it and he was feeling great. So that bought us a little bit of time. We couldn't apply the nebulizers because there's too high of a pressure for the nebulizer to actually circulate into the CPAP turbine, so to speak. And then we have this other waveform here, and we can see that this really mimics mostly that delayed exhalation. However, it's much later in the game, as we can see here. Our waveform is actually relatively upright, and then we get some sloping at the end. Okay, and we can see that's relatively consistent throughout as well. So that gives me a good indication that this waveform is not an aberration, and we have some type of problem that we need to address regarding delayed exhalation and or bronchospasm, mucus plugs, what have you. So remember, when we're evaluating waveforms, we're looking for the regularity of the waveform, the rate of the respiratory rate, and the size of the waveform, which will be reflective immediately of our end tidal level, and then also the shape of our waveform. And so is it abnormal or is it normal? And in the case of a bronchospasm, we know it's an abnormal waveform. We can readily identify it, and that's really diagnostic. That's a diagnostic measure of what's going on with the lung volume. Is it being restricted or is it normal? Here's a little bit of a different case, and this is where we're utilizing capnography on a patient where we're performing CPR. And where we work, we use Rescue Pod, which hopefully a lot of you are at least slightly familiar with. If not, we're going to talk about that another day. But the Rescue Pod, with it on, we get a nice clean waveform, which maybe we'll discuss later on as well. But this is a case where we were taking the Rescue Pod on and off because we thought we were getting back pulses, and we were confirming that. So we continued on CPR, and if you picture these two strips going end on end, this one being starting here, okay, two to 3 to 4. What we have here is exhalation and compressions continuing during exhalation, causing what are essentially oscillations. Those of you that don't use a Rescue Pod, you'll see that. But those of you that use a Rescue Pod, the mechanism of the Rescue Pod creates a negative vacuum in the chest and actually creates a very nice clean waveform, even despite all of the best CPR. So it's actually nice to use a Rescue Pod simply to clean up the waveform so we can get a better indication of what may be going on with the patient when we start thinking about our H's and T's and coming up with a resuscitation plan for those types of patients. Here's another patient that we had post-resuscitation cardiac arrest, and we have this patient sedated. However, we keep on getting all of these little blips in here, and we can see that the waveform is actually relatively normal, except we have these little aberrations. However, the rate is irregular, okay, and the waveform is normal looking, like I said, and the size is relatively good and consistent as well. However, what's happening here is, especially in this one area here, we call that a Curare cleft. And what that typically means is that for our purposes, this patient is sedated but may not be sedated enough, and their body is trying to overcome the ventilator. So what this patient most likely needed was increased sedation in order to reduce the stress on the body. Because what happens is when this patient isn't fully sedated, it actually can cause additional problems and stress on the body and delay recovery. It's also important to know that if we had a waveform that was abnormally high, okay, either due to a bronchospasm or just high in general, the patient may actually have a reflex Curare cleft based on this status, okay? Because the body doesn't like all that extra carbon dioxide, because that carbon dioxide is an acid, correct? So the body is actually trying to be proactive and expel more carbon dioxide, because the rate that we are controlling that patient's ventilatory status is probably not fast enough for the body's needs to expel carbon dioxide. Okay, so we may actually need to use that clue for the Curare cleft or the interruption in respiratory pattern, which we see here, okay, where this is not, this might be manual ventilation, whereas this here and this here may actually be the patient that is trying to breathe on their own. If we see this with that low, that excessively high end tidal level, then we may need to not necessarily just consider extra medications, but do we need to correct this abnormal level of carbon dioxide floating in the bloodstream and in the lungs. Here's a great example of an abnormal waveform that may or may not be related to what we just discussed, with the patient either trying to override the ventilator due to lack of sedation or the fact that they're hypercarbic and their body is becoming more and more stressed because of the hypercarbia and trying to override what we're doing for them, which is not enough. So what we have here, this was a COPD exacerbation and cardiac arrest. In cardiac arrest before we got there, and we began doing our CPR and ventilating, and in this process of hooking up the end-tidal capnography with the bag valve mask and subsequently with intubation as well, we get back pulses relatively quickly after intubation, and over the course of time we start getting this waveform. And when we first had her waveform was very shark finny, okay? There was no doubt in our minds of what had happened with this patient. Okay, she had a difficulty breathing to begin with, history of COPD, and her inhalers weren't working for her, and unfortunately they called for us too late. Now, what is probably happening here is that even though we got some normalcy here, we can see that her end tidal shoots way up. So she may have been fighting us a little bit at this point, okay, after resuscitation. However, this may also be that patient trying to overcome that carbon dioxide building up at really the level of the bloodstream and the alveoli, and it's being trapped by that restriction or constriction of the bronchioles, okay? So another abnormal waveform, if we see something like this, we really have to look at correcting the cause. And in this case, this patient had to be treated very aggressively. Not only were we doing inline nebulizers, we were also going the route of magnesium sulfate for this patient to reverse that constriction of the bronchioles as quickly as possible, which in this case mag sulfate is completely justified. Which did help, but unfortunately these patients, they've been suffocating so long from that bronchoconstriction that their bodies and their brains just are not able to overcome the amount of hypoxia for the duration of time that they had even prior to going into cardiac arrest. So these waveforms may look relatively normal, and I wouldn't normally get too upset about them, but something to remember here, okay? First of all, relatively good rate, nothing to get too worked up over. Relatively good levels, or around 35 or so, and relatively good waveform. However, what's going on right here? Well, we haven't covered it too much, but we did discuss our baseline is usually at 0 after inspiration, okay? So post-inspiration or post-inhalation is right at this 0. So here's the patient inhaling. However, they're not getting all the way down to the baseline. So what this might mean is that this patient is not able to inhale completely because of some type of air trapping. And we've probably heard somewhere along the line of patients auto-peeping. Well, there's a potential that this patient could be auto-peeping, though our waveform is relatively normal. But there may be some reason that this patient is rebreathing carbon dioxide, okay? It could be from being on PEEP or CPAP, where there's a little bit of a carbon dioxide, where if you think about CPAP is causing that restriction of exhalation, you may actually be retaining a little bit of carbon dioxide over time, causing your baseline number of 0 to actually rise, okay? Something to be aware of, and if you see it, it's definitely worth the justification to figure out what it was or what's causing it. And so here's another set of strips, and this is all the same patient. And if we look at this right away, we can obviously see a very consistent pattern of inconsistency. Okay, we don't have any regularity of normal waveforms anywhere, do we? So if we're just staring at this going, what the heck's going on with the patient, then we're missing out on a very important opportunity of looking at our patient and comparing and contrasting what we're seeing. So all this really was for this patient was this patient was talking. Okay, so we can easily have what we consider artifact, which is what it is, just the same as if you have a patient that's on a 12 lead and they're talking or they're shaking or moving around. We're not going to get a good sample of what we're looking for. Okay, so in this case, yeah, maybe the patient didn't really need to be transported to the hospital, let alone have capnography. But it's also a great illustration of what you might see at one time or another. Now, if we had a patient with a decreased level of consciousness and we had these types of waveforms, well, we know they're not talking anymore. So now we might be thinking that their tidal volume's not adequate, and their respiratory rate, not respiratory rate, but their respiratory effort needs to be assisted, or maybe there's some kind of underlying problem, such as the patient is an overdose or something. We need to correct that first before we get too heavily involved in intubation or what have you. So that wraps up our waveform analysis for today. That won't be the last time we see our waveforms though, because remember, when we evaluate the patient, we are evaluating the waveform, and we're evaluating our numbers or our levels, and we're also evaluating our trends, how that waveform and those numbers look over the course of time. Remember that we need to do a complete assessment with our capnography, and that would include incorporating that capnography and looking at all the things that we're attempting to teach you today and past and future episodes. The more you use it, the more you learn, and the more you learn, the more you want to use it. Remember, ventilation, perfusion, and metabolism, all three need to be present for carbon dioxide production, and we need to remember that we can utilize that method of ventilation, perfusion, and metabolism to determine what may be going on at the patient. Is it just respiratory? Is it respiratory and perfusion? Or is it all three? So for now, good luck. Start working on things, and we'll see you at the next episode. Take care.